Hi, good evening, Dr. Prem. I see you online as well. Dr. Prem Kumar, right? Oops, sorry. Okay, Afiq, it's 301. Dr. Liu and Dr. Kaitri, if you are ready, then we can formally start.
Yes, can.
Yep.
Okay. All right. So a very good evening to everyone in attendance. Welcome to our College of Physicians weekly webinar. We are currently in the third week of the month of hematology, and our topic today is titled The Approach to Aplastic Anemia. Before we formally start, I have just a brief announcement from Dr. Firdaus, who is our council member from the College of Physicians of Malaysia. So the College of Physicians of Malaysia is basically a representative body representing the physicians of Malaysia. And we strongly encourage representation and for physicians to join the membership. All right. So just a disclaimer, this membership is currently strictly only for NSR registered internal medicine physicians. For those who are interested or who wish to know more, you can visit the Academy of Medicine website and go to the online membership registration. So there's more information over there. Okay. With that, I would like to introduce our chairperson for today, Dr. Liu Hong Keng. He is currently a consultant clinical hematologist at the Hospital Sultanah Bahia in Kedah, a position which he has held since March 2013. Throughout his tenure with the Ministry of Health, he has served in various hospitals from Taiping, Bukit Mertajam, Penang General Hospital, Temerloh, and had a fellowship training in Ampang and also in the Alfred Hospital in Melbourne prior to returning to Malaysia. So he has published widely in many peer-reviewed journals and is also active in clinical research trials. So with that, Dr. Liu, I would hand over the floor to you to introduce our speaker and to continue the session.
Good afternoon, everyone. Thank you, Eugene. Thank you for the kind introduction. Firstly, I'd like to welcome all the participants to this session. It gives me great pleasure to introduce our speaker for today, Dr. Kaitri Raghunathan. She's a clinical hematologist at Hospital Queen Elizabeth in Kota Kinabalu, Sabah. She did her training at the Queen Elizabeth Hospital in Kota Kinabalu, as well as Ampang Hospital, the National Hematology Center in Malaysia. Besides that, even prior to her training, she has experience in various locations, including already in hematology at Penang Hospital. So, and Sabah has its large share of cases of aplastic anemia. So it's, very apt that Dr. Kaitri would tell us today about the management of aplastic anemia. With that, Dr. Kaitri, I pass the mic over to you.
Thank you very much, Dr. Liu, for the kind introduction. Thank you to the College of Physicians for this opportunity. And thank you, Eugene, for the arrangement. Thank you, everyone, for participating in this. So today, I'll take you all through the diagnosis and management of aplastic anemia. So this will be the outline of my presentation. So some fun facts first. So humans, actually, we have about 10 to 20,000 of true hematopoietic stem cells, and each hematopoietic stem cells only divide once in every 50 weeks. And it's the origin of 100 billion of new blood red cells that are produced. We can actually live a lifetime with only less than 10% of this hematopoietic stem cell pool, which is what happens in our bone marrow transplant patients. So before we go into the topic of aplastic anemia, let's talk about bone marrow failure as a broad topic first. So bone marrow failure is defined as an intrinsic disorder of the bone marrow, which is due to disrupted hematopoietic stem and progenitor cell homeostasis and function. It results in inadequate production of white blood cells, red blood cells, and or platelets. So bone marrow failure per se can be divided into an acquired form or inherited form. It is very important for us to actually differentiate these two categories because the management of the inherited and acquired form may be somewhat different. So our topic of interest will be the acquired aplastic anemia today, but nevertheless, let's just go through the other disorders that are present in this bone marrow failures, which are in the acquired form. You have pure red cell aplasia, hypocellular MDS, PNH, transient drug suppression, transient infection, and vitamin or mineral deficiencies. And in inherited forms, in the younger age group, which means that up to adolescent group, you can also see patients with Fanconi anemia, Diamond-Blackfans usually in the childhood, dyskeratosis congenita, and thrombocytopenia syndrome, Shrushman-Diamond syndrome. So aplastic anemia, our topic of interest, is defined as pancytopenia with hypocellular bone marrow in the absence of an abnormal infiltrate or bone marrow fibrosis. So it's basically a diagnosis of exclusion after excluding the other conditions that I mentioned in the diagram before, in the slide before this. So the incidence, usually there's a biphasic distribution with peaks at 10 to 25 years and over 60 years. Incidence is about 2 to 3 per million per year in the Europe, but higher in East Asia and very high in the place I currently work. So acquired aplastic anemia, the etiology can be divided into a few types. So basically the immune mediated are the commonest cause, which account for about 75 to 80%. Drug or chemical effect about 3 to 5%, which is usually due to chemotherapy, benzene exposure, antiepileptics. Hepatitis associated at about 10 to 15%, and viral infection associated like EBV, HIV, or parvovirus induced. But having said that, this hepatitis associated and viral infection can eventually turn into an immune mediated type and also cause acquired aplastic anemia in an immune mediated form. So as a broad classification, diagnosis of aplastic anemia needs a hypocellular bone marrow and two of the following: hemoglobin concentration of less than 10 grams per deciliter or 100 grams per liter, platelet count less than 50, and neutrophil count less than 1.5. But I'm sure many of you are familiar with this classification, which is the Kamita criteria that we commonly use for classification of severe aplastic anemia. But the diagnosis per se actually requires the platelet count of less than 50, neutrophil count of less than 1.5, and hemoglobin of less than 10. However, why did they come up with this Kamita criteria? So Kamita is actually, Bruce Kamita was actually a pediatrician who saw a lot of cases of aplastic anemia and decided to classify these patients into non-severe and severe and very severe into one group and non-severe into the other group, basically for the reason of subjecting these severe and very severe patients for bone marrow transplant. So non-severe patients do not actually need to undergo bone marrow transplant. So let's go through the criteria for severe aplastic anemia. So severe aplastic anemia means there's bone marrow cellularity of less than 25% of age, or 25 to 50% cellularity with less than 30% hematopoietic cells. To make things simple, just remember bone marrow cellularity of less than 25, and at least two of the following, which means that neutrophil count is less than 0.5, platelet count of less than 20 times 10 to the power of 9 per liter, and reticulocyte count of less than 60 times 10 to the power of 9 per liter. Bear in mind that these units may be very different for your hospital, depending on what your hospital standard units are. And very severe aplastic anemia, on the other hand, basically it's the same criteria as severe, except that the neutrophil count is much lower in 0.2. So as mentioned earlier, so these two patients need special attention and needs to be seen early, referred early, and diagnostic and workup has to be done for them very fast. So what we mean by hypocellular bone marrow, this is an example of a trephine biopsy of a bone marrow of a patient with aplastic anemia. So a cellularity of, you can see all these empty spaces here. So if the patient is about 20 years old and you expect that 100 minus 20, you expect 80% of this to be filled. But if this patient is 20 years old, you would expect only about 10%. You can see some cells in between here. So this is probably like a cellularity of about 10%. So this is a hypocellular bone marrow. So this is Bruce Kamita, who back in the 1970s, they decided to come up with this criteria just to make sure to prospectively study the effect of early marrow transplantation on the severe and very severe patients. So let's go on to the pathophysiology of aplastic anemia. So basically what happens in aplastic anemia, it is actually a very complex problem, but to simplify things, what happens is that when a patient has an exposure to a virus or chemical or any trigger, there is an autoimmune T cell response that happens in the patient. So what happens is that the patient has these antigen presenting cells that recognize this antigen, and this antigen will then be translated and produce an autoimmune response, which will result in hyperactive T cell activation. So there's an auto T cell activation, and this T cell activation and expansion, which then leads to bone marrow, will migrate to the bone marrow. And these cytokines that are released from these T cells, which include the interferon gamma, TNF alpha, and fast-mediated apoptosis, will actually result in marrow stem cell killing. So steps that lead to the stem cell destruction is basically the presentation of the autoantigen by the antigen-presenting cells, okay? And then there's dysregulated activation of the autoreactive T cells, and then there's T cell expansion and differentiation, and the cytokine-driven hematopoietic stem cell apoptosis and reduction in cell cycling leading to marrow aplasia. So what are the investigations we would do? So generally, let's talk about a patient who comes in with pancytopenia first. So when a patient comes in with pancytopenia, generally everybody will definitely send a peripheral blood film. So in a patient with aplastic anemia that you suspect to have aplastic anemia, you would actually get pancytopenia. So you will get reduction of all cell lines on your peripheral blood film, and you frequently see macrocytosis and anisopoikilocytosis, different sizes and shapes, and you need to exclude the presence of any dysplastic neutrophils, abnormal platelets, blast cells, or any other abnormal like mononuclear cells that may suggest that this patient probably has an infiltration of the bone marrow due to something else. And also we do a reticulocyte count, an absolute reticulocyte count of less than 60 × 10⁹ per liter. Viral screening, like mentioned earlier, hepatitis B, C, HIV, parvovirus, EBV, autoimmune screening, vitamin levels, B12, folate. Okay, so these are the general investigations that we'll send first, depending on the severity of the patient's pancytopenia. Say if the patient has got a neutrophil count of less than 0.2, and it's probably not advisable to wait too long, and definitely to counsel the patient for a bone marrow aspiration and trephine biopsy as soon as possible. So the next investigation that we would do for this patient is bone marrow aspiration and trephine biopsy and cytogenetic or FISH analysis. So a good quality trephine biopsy specimen of at least 2 cm is essential, as you would a 2 cm sample is good enough to assess the overall cellularity and also the morphology of any of the other residual hematopoietic stem cells, and also to exclude abnormal infiltrates. Say, for example, like in lymphoma, occasionally there are like clusters or just like occasional nodular infiltration. So we generally have to exclude all these before we come to a conclusion of aplastic anemia. If the patient is young and you think there are features or on examination that features to suggest that this patient probably has an inherited bone marrow failure syndrome, we can do something called the peripheral blood DEB, diabetic epoxy butane test, or mitomycin C for chromosome breakage. This is not easily readily available in Malaysia, but I think for mitomycin C we can send to HUSM, but there's a cost that we need to pay for it. I think it's about 300. So you can do that. So mitomycin C for chromosomal breakage to suggest possible Fanconi, or even better if the patient can pay for a genetic panel to look for inherited bone marrow failure syndromes. And also a flow cytometry for GPI anchor protein to detect PNH clone. This is from the latest British Society of Hematology guidelines that recommend sending the PNH clone at the very beginning when you actually suspect a patient with, if the patient has aplastic anemia. And I'll tell you why, what is the benefit of doing that in the beginning itself. So again, this is a normal bone marrow, very busy. There's a lot of cells here. You can see that this is an empty bone marrow, hypocellular with very minimal cells. These are all adipose fat cells with a lot of space in between. So this is a hypocellular bone marrow. This is a compact normal bone marrow. So the other important thing is that we should differentiate a very frequently associated condition and difficult to differentiate at times, aplastic versus hypoplastic MDS. And this is from the ASH guidelines that a few features that can help you to differentiate hypoplastic MDS from aplastic anemia, whereby the marrow cellularity, occasionally hypoplastic MDS, you do get a cellularity of less than 10 as well. But in MDS, you get some blasts and you can get some dysplasia, ring sideroblasts, reticulum fibrosis, and you can get like monosomy 7, chromosome 5 abnormalities, and somatic mutation may be present in both. But aplastic anemia would usually have, sometimes if PNH clone is present, is more suggestive of aplastic anemia. So there is a HG score, which is a hypoplastic MDS score that you can score based on these criteria. And if a score of more than 2 is highly specific for the diagnosis of hypoplastic MDS. And this again, clonal hematopoiesis, the reason we send cytogenetic for a patient with suspected aplastic anemia is, number one, to differentiate if this patient is hypoplastic MDS as well. And also you can monitor the patient. If say the patient has monosomy 7 but does not have any other features of MDS, then this patient may progress due to this clonal hematopoiesis, may progress to develop acute leukemia earlier or in the future. So we have to closely monitor these patients. So let me take you through the approach of how we what do we do when we suspect a patient with aplastic anemia. So first of all, a thorough history and clinical examination is important. So ask for symptoms of infection, like exclude HIV, hepatitis, medication history, any patient on long-term Bactrim, and any other medication that can cause cytopenias. Toxin exposure, like benzene exposure or pesticide exposure, family history of bone marrow failure syndromes, height and weight. If the patient is like short stature, you might suspect the patient could have inherited bone marrow failure syndromes and any congenital anomalies. So these are the clinical examination to suggest that these are inherited bone marrow failure syndromes, like short stature, skeletal defects can be observed in Fanconi anemia, dyskeratosis congenita, and skin pigmentation, pancreatic insufficiency, nail dystrophy, lung fibrosis, lymphedema. These are all features that may suggest this patient has got inherited bone marrow failure. So, and then you confirm the diagnosis with relevant blood investigations as we have discussed, and also bone marrow aspiration and tryptophan biopsy. And then you determine the severity. So based on the bone marrow cellularity and the patient's counts, we determine the severity, whether this is a VSAA or very severe aplastic, or is this a severe aplastic or is a non-severe aplastic. And then we look for concomitant clones. So as I said that just now, so usually PNH clone, we do a peripheral blood to detect a PNH clone. And the reason for doing this is because there are studies to suggest that if there's presence of PNH clone, you can be rest assured that you're not dealing with the inherited bone marrow failure syndrome. And number two is that if there's presence of PNH clone, the patient may respond to immunosuppressive therapy slightly better than a patient without. So these are just things to support. So, and then of course, in a young patient, we exclude inherited bone marrow failure syndromes like inherited gene panel, DEB test, mitomycin test. And then you go on to, then you sit down with your team and you decide what is the definite management for this patient. Should this patient undergo a hematopoietic stem cell transplant, whereby you need to do an urgent HLA typing, or should this patient get immunosuppressive treatment? So let's go on to the management. So the age of the patient is very important, and the comorbidities are important. So basically, the cutoff usually used for transplant in aplastic anemia is less than 40 versus more than 40. But things are changing. There are papers suggesting that if a patient is very fit, age can even go up to 50 years old for HLA identical sibling transplant. So it depends on your transplant team, and the patient's comorbidities and fitness level, and you may subject the patient to a bone marrow transplant if the patient is very fit. This is because actually bone marrow transplant basically gives the patient a cure, and whereas immunosuppressive therapy does improve counts, but it does have some other side effects that, patient may fail, they can relapse, or they can have clonal evolution later. So as much as possible, we would try to do a bone marrow transplant to give the patient a cure if the patient is fit. But of course, bone marrow transplant is by itself not without its complications. So obviously we need to discuss with the patient as well. So if less than 40 years old, we do a HLA identical sibling donor. So this has to be planned very fast, and especially in our setting, we actually can get a HLA typing result very fast if you can prime and call for an urgent test. So places like PDN, Pusat Darah Negara, and also IMR does HLA typing. So we can call these two centers and say you have a patient with severe aplastic anemia, and usually they'll give you a date for HLA typing within a week, within 5 days to a week. So you really need to be fast and try to get a transplant, a HLA date as soon as possible, and then get a HLA typing done for the patient. So if the patient has a HLA identical donor, the patient should go for a HLA matched sibling hematopoietic stem cell transplant. However, if the patient does not have a HLA identical donor, so the patient should go on to receive immunosuppressive therapy with ATG, cyclosporine, and L-Thrombopec. Okay, this is plus minus. And then, so if a patient is more than 40 years old or more than 50 years old without a matched sibling donor, or if the patient is more than 40 years old and you have not done a HLA typing as well, the patient should get ATG plus cyclosporine plus L-Thrombopec. However, the patient, if there is no response, you can subject the patient to match unrelated donor if the patient does not respond to this immunosuppressive therapy. Certain non-transplant options, if the patient does not respond to the standard IST, is either you go on for a second ATG. So the first line usually we use is the horse ATG, and second line we usually use the rabbit ATG. I'll be talking about this in the next few slides. So non-transplant options other than that include like L-Thrombopec using like androgens, synthetic androgens like danazol. Alemtuzumab is not readily available to us. Other novel therapies or even clinical trial if available. So as I mentioned earlier, adult hematopoietic stem cell transplant survival is age dependent, but between the ages of 30 and 50, overall survival is about 70 to 90%. So we first have to select the type of donor. So usually the first thing that we do is we look for a matched sibling donor. So if there's no matched sibling donor, the patient will undergo an immunosuppressive therapy first, and then if the patient doesn't respond, either will get a match unrelated donor or haploidentical or even cord blood if available. So we need to, after that, you need to liaise with your transplant team, and then selection of the donor, conditioning regimen, and stem cell dose, and the source of the stem cells. So some of the patients, if they have the same blood group as the donor, so they will get a bone marrow graft. And if the different blood group of the donor is not very keen to do a bone marrow graft, then a peripheral blood stem cell harvest will be done. So of course, and these patients who go for stem cell transplant are relatively young, less than 40 years old. So you need to address fertility issues, maybe sperm banking or oocyte retrieval can be discussed with them beforehand. So immunosuppressive therapy. So we've spoken about transplant. So immunosuppressive therapy is indicated for non-severe aplastic anemia who are transfusion dependent. As I mentioned earlier, that non-severe aplastic anemia, the hemoglobin criteria does not fall into it does not come into the Kamita criteria. But we do see some patients who are transfusion dependent, but their neutrophils and their platelet are actually quite normal. They are in the acceptable range. So these patients can be subjected for immunosuppressive therapy with ATG and CSA. And however, the main indication for immunosuppressive therapy with CSA and L-Thrombopec in this era will be severe aplastic anemia in the absence of a matched sibling donor, or severe aplastic anemia or very severe aplastic anemia with a matched sibling donor and age of more than 40 years old. So a little bit on ATG and CSA L-Thrombopec. So anti-thymocyte globulin is basically produced by immunizing animals like the horse and the rabbit against human thymocytes. So we inject the animals with human thymocytes, and then they produce the antibody, and we collect the antibody to actually be given to this patient. So this anti-thymocyte globulin is obviously associated with a lot of infusional reactions, and so they should be carefully monitored during infusion. need to use a central venous catheter and steroid use during the infusion, and also to prevent serum sickness. It's because due to the antibody created by the animal. And then we also need to support these patients with platelet transfusion before and after, maintaining platelet count more than 20 times 10 to the power of 9 per liter, because there is consumption of platelets during when this anti-thymocyte globulin is given. And then cyclosporine basically has a selective effect on T cell function, whereby it inhibits the expression of some regulatory proteins and reduces the T cell proliferation and activation, and also helps to increase the T regulatory cells in our body. So it's usually started at day 1 of ATG at a dose of 5 milligram per kg per day to achieve a trough level of 200 to 400. And L-Thrombopag, not a very new kid in the block, but has been around for almost a decade. So this is a thrombopoietin receptor agonist. So thrombopoietin is actually very important for our platelet production, because it stimulates your megakaryocytes in the bone marrow to produce, to increase megakaryocyte production and therefore increase your platelet production. However, it has a distinct property that could be effective in stimulating the hematopoietic stem cell per se, that at a very precursor level. So, and hence L-Thrombopag has been studied and has been found to actually, when added to ATG and CSA, has through this study, RACE study, has actually increased the CR rates at 3 months to 22%, and overall response rate at 6 months to 68% versus 41%, and shortened the median time to response. So besides that, the L-Thrombopag also has an effect on the hematopoietic stem cell, stimulates the hematopoietic stem cell. It has some immunomodulation, ion chelation effect, and it promotes tolerance. So coming to the next slide, what are the factors predicting response to IST? So usually in a patient who's young, they generally may respond to IST better. Use of horse ATG, presence of a PNH clone, reticulocyte count of more than 25, not too low, so they may respond to the IST better. Lymphocyte count of more than 1, not severe disease, and cytogenetic like addition A, deletion 13q, and so on. So after you've done the IST, what would we want to monitor? Our goal is basically we aim to achieve a gradual blood count recovery over the first 6 to 9 months. So complete response is defined as normal blood counts, or even if when platelets are more than 100. And partial response when you achieve a transfusion independence or neutrophil count of more than 0.5. And treatment failure is defined, definitions vary across different centers. Basically, if the patient is still transfusion dependent and ANC recovery is still less than 0.2 by 3 months, it's considered treatment failure. So next is when we see a patient who has undergone IST and they have responded quite well, how do we wean the cyclosporine down? So we start weaning the patient cyclosporine down after 6 months, and usually wean by about 10% every month or 20 to 25% every 3 months. And evidence of falling counts during weaning, you may choose to actually resume the full dose of cyclosporine or pursue an alternative treatment. Like say if the patient did not have a stem cell transplant and if the counts are dropping very quickly, and you know that this is not a sustained response, so you may want to talk to the patient if they want a stem cell transplant to be done. And long-term follow-up, once you have withhold or stop the immunosuppressive therapy like cyclosporine for the patient, you have to wean down and stop the cyclosporine. These patients need to be followed up indefinitely, because once we have given the patient immunosuppressive therapy, they are at risk of developing myelodysplastic syndrome transforming to acute leukemia. So this should be monitored every 1 to 3 months for the first year, and at least 6 monthly to yearly subsequently. And if the counts are dropping, remember to also check PNH clones, because these PNH clones can then predominate in these patients. So the other thing is supportive management. So we've spoken about stem cell transplant, we've spoken about immunosuppressive therapy. Supportive treatment, basically red cell transfusion, thresholds of about 7 grams per deciliter. Platelet transfusion for patients on active therapy for a platelet count of less than 10. This is also, you also have to look at the patient. If the patient is has a bleeding phenotype, then probably your threshold would be higher. So if the patient has had intracranial bleed in the past, then I think we would definitely take a higher threshold of platelet count. Asymptomatic patients with chronic thrombocytopenia, prophylactic platelets are actually not recommended, but this requires an assessment of clinical bleeding risk. The reason is that we often encounter patients with aplastic anemia due to their very high autoimmune activity in their body. So they definitely tend to develop platelet refractoriness easily compared to other patients who are transfusion dependent. So I guess if the patient is not symptomatic, so bleeding, our threshold for transfusion should be much, much higher. So tranexamic acid in patients undergoing intensive chemotherapy suggests no benefit. However, it may be considered in patients with aplastic anemia. The need for iron chelation should be decided on an individual patient basis, and aplastic anemias who are severely neutropenic should be given prophylactic antibiotic and antifungal according to local policies. So let's talk about management of aplastic anemia in special situations. So pregnancy. So pregnancy itself can cause aplastic anemia, but this is quite rare. It can spontaneous remission occurs in about 25 to 30 patients once the baby's out. And in the first trimester, pregnancy can be terminated. While in advanced pregnancy, patients can be followed up with stringent supportive care, basically with supportive platelet transfusions. And for pregnancy, your platelet levels should be maintained above 20. And cyclosporine is also safe in pregnancy if it's needed. And patients with established aplastic anemia should avoid pregnancy as if they are stable, it can actually induce a relapse when they become pregnant. And how do we manage aplastic anemia in the elderly patients? So elderly patients with aplastic anemia should be individually assessed, and IST is considered the treatment of choice. So ATG and cyclosporine results in more rapid recovery of blood counts, but alternatively, cyclosporine alone, L-thrombopeg, or anabolic steroids can be considered. So many times we actually counter like a patient with 67 years old or 70 years old, not too fit. We actually start monotherapy first, and then we actually see how they go about. And because ATG itself has its own risk because it's quite immunosuppressive as well. So coming to my last few slides. So I didn't talk about danazol earlier. So like in an elderly patient, you can start patients on danazol because danazol is actually an synthetic androgen, and it has early studies have showed that this androgen actually enhances the responsiveness of erythroid progenitors to erythropoietin, and it actually enhances the growth of the pluripotent and committed granulocyte macrophage progenitor. It also helps to inhibit the interleukin and TNF alpha, which is involved in the pathophysiology of aplastic anemia. It also stimulates erythropoietin production and release, increases the telomerase activity in hematopoietic cells. So this is the latest guideline from the British Society of Hematology, and it was just released into 2024. They have a lot of revision of the previous guideline. So if you're interested, you can go and look up on this. And these are my references, and I'm happy to take any questions. Thank you. Okay.
All right. Thank you, Dr. Gayatri, for bringing us a comprehensive review from the diagnosis and management of aplastic anemia. Now, the floor is now open for questions to Dr. Gayatri. Any questions?
Questions?
Maybe I can start with one while waiting for the participants to ask.
Okay.
Any postulate why the cases in Sabah seems to be, well, the incidence seems to appear to be far higher than many places around the world?
I think there is one analysis a few years ago. I think Dr. Agnes did a survey and say that there's a HLA predilection among the Kadazan Dusun people that has resulted in more cases in Sabah rather than other places. And also, we do also see that this are more concentrated in the area where in Kota Kinabalu and Keningau and so on, whereas in the other side like Lahad Datu and all, we don't get that many cases of aplastic anemia where the population like more Bajau and so on. So maybe it's the ethnicity and probably also the agriculture pesticide exposure Yeah, because of probably due to that, but there's no real reason that we have found out, I guess. Maybe Dr. Lily will know a little bit more.
Right. The other thing is, in your practice, up to what age do you screen for Fanconi's anemia?
So
Because it can be variably, presented. Some patients present very early, while some can have very mild
correct.
asymptomatic presentation and may go unnoticed until much later.
So I think depends as I think
I know it's difficult, but
in the past we didn't really screen that much, but I think now as we are more aware, and also I think when I was in Ampang, we actually had a patient transplanted with Fanconi's, so we had a bit of my exposure of what how to actually screen and what are complications associated with transplant in Fanconi's as well, because I think the problem is they have poor DNA recovery. They basically have poor DNA recovery, so they can't actually heal properly. So probably the conditioning regimen and all will be different, and that's why it's quite important to differentiate the both. But in my experience, I think when I was in Sabah, I think we've screened about 2 to 3 patients, and it turned out to be negative from the metromycin test, which we sent to HUSM. So
I've personally not picked up one except for a case when I was doing my training in Ampang, I believe. And of course, the other reason for screening is you certainly don't want to pick a family member who's also
correct. Exactly, the donor who's
the
also
donor is also actually,
underlying that.
asymptomatically carrying the mutation.
Correct.
We still, yes, looks like there is a question from the audience. If the patient has responded to triple IST, what will be the suggested sequence of tapering for the cyclosporin and L-Thrombopag? Is it still recommended to keep the cyclosporin for 2 years before tapering? Let's do the first part first. What's the suggested sequence of tapering for cyclosporin and L-Thrombopag?
So usually L-Thrombopag is kept for a definite duration of about 6 months. Okay, so usually we do not extend L-Thrombopag beyond that. And if your patient has achieved good response to that, so we take the L-Thrombopag out first, and then we start tapering the cyclosporin after 6 months. So you can start tapering, as I said, by 10% monthly or 20 to 25% 3 monthly, slowly over 2 years.
For the L-Thrombopag, do you just stop at 6 months, or do you also
depend on the response?
Reductions?
So depends on the response. So usually we tend to, if the patient, because L-Thrombopag is also quite costly. So if the patient has responded very well in your 3 or 4 months, so probably at the 4th, we try to keep it to 6 months, but maybe at the 4th month, you can start tapering it down already. But very, very slowly, close monitoring, and you can look for relapse, and you can push the L-Thrombopag up again if your patient's counts are dropping again. So yeah, because there are studies that kept L-Thrombopag for 3 months or 6 months, and obviously they say the 6 months response is the best. But I think obviously cost is an issue with L-Thrombopag as well. But if you're giving the patient a good 6 months duration, then that will be good before you decide to taper.
And the cyclosporin, do you keep for 2 years before tapering, or as what you mentioned is after 6 to 12 months, then you can start to taper.
Yeah.
But how fast do you taper? Or because I know there are people who like to keep for 2 years first before tapering. What are they try and taper over the course of a whole year or so?
So we go very slowly, like I mentioned, I think about 10% per month, or every 3 months about 20%. So you cut down like probably 25 milligrams. And if the patient is stable and you see any signs of relapse, you probably increase the dose back. So is there another question? Secondary centers without resident hematologists, after BMAT is done, is there any role of GCSF while waiting for hematology review at tertiary centers?
Yep.
Generally, okay, so for secondary centers without resident hematologists, after BMAT is done, is there any role of GCSF while waiting for hematology review at tertiary centers? So I think generally, GCSF is not recommended because it's not going to be useful. So, but the thing is, if you are at a center that and you need, and the patient's counts are really very low, I think there's an urgency to refer to the tertiary center and for them to take over as soon as possible. But GCSF generally does not help that much unless you're in a desperate situation and the patient is having spiking fever, hemodynamically unstable, and you've got a bone marrow result that's back and you confirm it's aplastic anemia. Always we need to rule out acute leukemia and pancytopenia first, and then if you're confident that the patient has aplastic anemia and you think that patient may have some residual hematopoietic activity, then I think in that kind of situation, no harm to try push the neutrophil up while waiting for transfer or definitive treatment. But it's really not recommended in any guidelines. So it's just by situations, if the patient's very septic or so.
If I may add, I believe if it is a severe or very severe, they generally don't really respond to GCSF. The mild cases might, but then if they're mild cases or the non-severe, correction, the non-severe cases might, but if they're non-severe, usually those are not, GCSF is not needed in the first place.
Correct.
Yeah. Any other questions? Let's see. We still have some time. Yes, the case of severe aplastic anemia or very severe aplastic anemia, do you recommend long-term antimicrobial prophylaxis?
Actually, the antimicrobial prophylaxis is during the period of neutropenia. So if you have given the patient definite treatment and you have taken the patient, you have actually given the patient relief from their bone marrow is recovering, then I think antimicrobial prophylaxis in terms of neutropenia, you don't need, like ciprofloxacin that's recommended in most guidelines should not be given. However, if the patient has undergone bone marrow transplant, then the patient should be on the regular antimicrobial prophylaxis like penicillin V and so on, and antiviral prophylaxis and so on. Whereas for ATG, immunosuppressive therapy, even post-immunosuppressive therapy, we do not put the patient regularly on immunosuppressive, on antimicrobial prophylaxis if the patient's neutrophil has recovered, except for if the patient comes in with sepsis and so on. Yeah.
Looks like we do not have any more questions. The last call for any questions? No? All right. If not, then thank you very much. Firstly, I'd like to thank everyone for attending this session. Thanks to Dr. Gayatri for this comprehensive presentation. And so thank you to the College of Physicians for holding this webinar series.
Right. Thank you so much. So Eugene.
Yep. Thanks, Dr. Gayatri. Thank you, Dr. Liu, for the very informative session and for spending your evening with us. Thank you to everyone in attendance as well. For those of your friends or colleagues who were not able to attend live, you may check out the repeat video in our YouTube page. Okay, so with that, we'll see you all next week for our final session for hematology. Have a good evening, everyone, and have a happy weekend for those celebrating. For those who have a weekend on Friday and Saturday.
All right.
Thank you.
Thank you. See you, everyone. Bye-bye.
Thank you. Thanks, Afiq.
Yeah, thank you, Dr. Eugene.
Thanks, Afiq. See you.
All right, see you, Dr.